So I'm going to hand it over to Dr. Redfern to begin his presentation.
Hi, everyone. Afternoon in my part of the world, and for most people, I'm assuming it's afternoon and a sunny day where I am. Apologies for the sun shining on my forehead through my office window. Okay, hopefully you can all see my slides there.
Yes, we can see them.
Go back a bit. Okay. All right. So first of all, thank you very much to the organizers, Rory and Steve and AFM, for the invitation. It's a huge privilege to be invited to give this webinar. And I'm going to basically be just covering various aspects of the pandemic that are relevant to children. And then hopefully we'll have some discussion and learn from each other and hear from you and your experiences at the end. As Roy said, I'm based in Cape Town, and we have been in the trenches for about 4 months or so now with the pandemic. I'm going to start off with some sort of basic facts that I think now are largely beyond dispute and probably very well known to you. So fact number one is that children are much less likely to acquire SARS-CoV-2 than adults. Worldwide, children across from China to the US and Europe account for between 1 and 3% of cases. It's also very clear that they have much less severe disease on the whole. In fact, as many as 90% probably of pediatric infections are either asymptomatic, mild, or moderate. And only about 10% are severe and requiring hospitalization. It's also clear that they're very unlikely to die from COVID-19. And the other encouraging thing is that vertical transmission from a positive mother to a newborn baby seems to be exceedingly rare. So having said all of that, we can probably just say, what's the big issue? Should we stop the talk there and carry on with more important stuff like how to deal with the adults? Hopefully not. Hopefully there's something more that we can say and of interest. I'm going to just quote some of the findings of this study from Dong, which was one of the original epidemiological studies in children that came out of China in about March. It illustrates a few things. The one is kind of the fact that, evidence has so rapidly changed during this time. And I was just reflecting as well on the fact that a lot of us have got a little bit of fatigue around COVID. And someone humorously tweeted a while back, I don't know if you're familiar with the concept of flattening the curve, but they were talking about it in reference to the literature around COVID. And can someone please stop publishing so that we can flatten the curve and keep up a bit? But this illustrates how our understanding has changed from when we were enthusiastically reading at the beginning, and now we struggling to find time to read as the clinical burden has changed, but the science has certainly advanced. The other reason why I wanted to show this slide, and I'm not seeing my cursor, let me just see why I can't see my cursor. Okay, I can't show you my cursor, is this classification has been used widely in the literature in terms of dividing children up into asymptomatic, mild cases, which is largely children with simply upper respiratory tract symptoms. Then what they defined as moderate, which was signs of a low respiratory tract infection, maybe crackles in the chest, maybe some shortness of breath or difficulty breathing, but without any hypoxemia. Severe was then classified as a pneumonia with hypoxemia. And in their cohort, certainly the under 1-year-olds formed the greatest bulk of this group. and then critical was defined as children that had an acute respiratory distress syndrome or a severe sepsis type picture, multi-organ dysfunction, myocardial injury, etc. Just a word of caution about this paper is that it was 2,100 children, but only 730 of those were confirmed cases. The rest were suspected cases. Relevant to this audience, who I'm assuming are in the frontline casualty emergency center type settings, is this paper from Italy, who were one of the hardest hit countries initially, where they looked at 100 children attending the EC, of which just over 10% were hospitalized, sorry, and about 20% were asymptomatic, nearly 60% mild, just under 20% moderate. Only 4% with SATs less than 95, 1% severe, 1% ICU. And I think that's certainly playing out in our experience. And in the recent sort of systematic review, looking at over 7,000 cases worldwide, that sort of breakdown is sort of reflective of the global what we've seen. Just to give you some insight into what is happening in South Africa. So this is our stats as of 11th of July, so just a week or so ago now. And you can see that the under 20-year-old population is vastly underrepresented, and they comprise about 6% of the total burden of cases nationally, and the older age group between 10 and 20 slightly more than the younger age group. If we look at outcome, again looking at our South African statistics, the blue line is the percentage of the population, and then again, if you look on the left-hand side, the under 20s, again, vastly underrepresented in terms of both cases, hospitalized cases, and deaths. Just a comment on the deaths, you can see there that they've accounted for about 0.4% of our deaths nationally, the under 20s. It's obviously difficult to try and keep track with all the information coming in. What I can say is that that number has grown, but from the earliest reports that we've had and where we do have information, like, for example, the cases that have occurred in my region, and you know the details, the vast majority of the children that have died have had very serious comorbidities. We've had children with dilated cardiomyopathy, cancer, severe obesity from a genetic cause, that sort of thing. Just looking at our experience locally in the province where I work, you can see that we had our first case just towards the end of March, and then we have been gradually increasing, and then the numbers have recently started to tailor down. What is important as well to consider is the impact of your testing strategy on your numbers. And so actually total number of cases is a very poor indicator of the spread and extent of the pandemic. In our context, we know that it's continuing to spread, but as of 1st of June, for example, we've only been testing hospitalized cases. You can see the age breakdown locally, and again, the older age group overrepresented. And what I wanted to just point out is that out of our 353 hospital admissions regionally, vast majority have been under 5 years of age. And we've had about a 7% hospital admission rate, with 16, at this time, 16 or so ICU admissions. Talking about transmission, what is interesting, particularly when one is having discussions around, for example, the back to school debate, is the fact that worldwide this disease seems to have occurred in family clusters, and between 75 and 90% is the sort of percentages that have been reported in the literature that children get have an adult contact or a known household contact when they contract the disease. It was slightly lower in that Italy study that I quoted earlier. And what this means is that children are very unlikely to be the index case in a household. And particularly children under 12, in other sort of transmission type studies where they've looked at this, they seem far less likely to transmit. So their R naught is much lower than older children and adults. The mechanisms and the risk of transmission from that large asymptomatic group of children, I am not aware of any evidence that clarifies that question for us at the moment, which is obviously an important one for us in hospital as healthcare workers, with the risk of asymptomatic transmission and obviously children going to school. Obviously begs the question, why are children getting off lightly in this pandemic? And definitely I'm no expert on this, and I think the knowledge is growing, but some putative theories at the moment. It has been documented before that the SARS-CoV or the coronaviruses access lung cells through the ACE2 receptor, and this has probably a reduced expression in younger children. So less virus gets in and they have low viral loads as a result. That's the theory around that one. It's been documented in the studies that have come out that children have less lymphopenia compared to adults and less pro-inflammatory response, which is probably a harmful response with things like interleukin-6. And so that might be protective. And then other studies, for example, the effect of vaccines like measles vaccine on co-protection against coronaviruses have been studied before. And also we know that comorbidities is a major risk factor in the adult population, and children on the whole have less obesity, hypertension, diabetes, those sorts of things. So those are probably some of the reasons why they are getting off relatively lightly. Are all children equally less likely, or are some more at risk to get infected or to get severe disease? I think we can say that the evidence on this is growing. In the systematic review I quoted earlier, there was about 655 cases in total from the studies that reported on comorbidities. And of those, the commonest comorbidities that seemed to be potentially contributory were children that were immune suppressed or with cardiac or respiratory comorbidities, which kind of makes sense. In our South African context, I can say that we had a national report where we've got statistics from all the people that have been tested, and about 20% of the positive pediatric cases had a comorbidity, the commonest being asthma. Having said that, probably we still don't know whether that's going to make you have more severe disease or more likely to get the disease or not. The clinical features are pretty non-specific. As I mentioned before, probably about 20% of infections are asymptomatic in children. And then out of the respiratory type symptoms, consistently across the world, fever and cough have been the predominant symptoms. But what is interesting is that compared to adults, children tend to have more diarrhea, vomiting, gastrointestinal type symptoms. We've seen a couple of interesting dermatological manifestations as well. In terms of labs, children seem to have a more normal white cell count than adults, but have raised inflammatory markers. Here's an example of a chest x-ray of a baby currently admitted in my hospital with a clinical diagnosis of bronchiolitis, and this x-ray, the findings, there have been a lot of normal x-rays, a lot of diffuse alveolar type patterns or patchy infiltrates, very typical of a viral pneumonia, as well as consolidation. So all of these have been reported. We don't use ultrasound routinely, and we're not CTing the chests routinely. But here you can see an example of that sort of diffuse pattern. Before I move on to management, I wanted to just put this up, which is our national guideline document on assessing severity of COVID-19 in children. It's not COVID-19 specific at all, and that's the point. It's as for any respiratory distress severity score as you would for community-acquired pneumonia or bronchiolitis or whatever. So you can see that the majority of children that would fall into the mild category, able to feed still or able to talk depending on their age, no significant respiratory distress, no oxygen requirement, would be discharged. Whereas children falling in the moderate category and then the severe category would be more likely to be admitted. So if we look at our current recommendations regarding management, if you're a mild case, it's simply a self-isolate at home, or if you're unable to self-isolate at home from a social perspective, then a quarantine facility. Panado for fever and to avoid ibuprofen, which has been shown to potentially have adverse effects in flu-like illnesses or flu. Avoid oral steroids, and this has been supported by the recent trial in the UK that for mild disease or for pre-hospital, steroids are associated with a worse outcome. Children that have diarrhea obviously need to maintain feeding and oral rehydration, and then just general home care advice around reducing viral load, cleanliness, reducing infection risk to others, that sort of thing. For the moderate cases, generally they're going to be admitted for observation at least. Normal supportive measures as you would for pneumonia, oxygen is needed, hydration is needed. We've advocated for MDIs rather than NEBs for wheezy children, and antibiotics no different from your local guideline for community-acquired pneumonia. For severe disease, it would depend on your context. So we offer a non-invasive respiratory support in a normal winter very frequently. So things like high flow nasal cannula, oxygen therapy, or CPAP. And of course, COVID has raised the concern around whether these are aerosolizing procedures, aerosol generating procedures or not, and whether that poses an undue risk to healthcare workers looking after these kids. The way that we have dealt with that is to try and only use these modalities in single rooms, and for staff to be protected via N95 masks and face shields and gowns and gloves, rather than the simple surgical mask which we're using for children that don't undergo aerosol generating procedures. We manage the majority of these children outside of ICU in what we call a high care type setting, but that obviously depends on your context. And for these severe cases, recently, based on the new evidence, we've started considering steroid therapy, particularly for children with very severe disease requiring ICU. I'm not going to go into any detail at all about the ICU management. For those who are interested or who would like to know more about that, there is a very excellent document prepared by the Paediatric Working Group of the South African Critical Care Society available on their website. I've put the link there. It really is around standard measures of safety, similar principles to adults in terms of trying to minimize the risk of transmission to healthcare workers during high-risk procedures such as intubation. There's also some guidance there on resource allocation, which we're obviously very good at in the being a low and middle income country. But I'm not going to go into detail on ICU management principles. Wanted to make a comment about upper respiratory tract infections. So obviously we're in winter here in South Africa, and the respiratory illness season commonly associated with children presenting with sore throat, upper respiratory tract type symptoms. We made a decision that to not assess the throat when a child presented simply with a sore throat in the child that was otherwise stable and looked well, had no signs of, for example, peritonsillar abscess or epiglottitis or anything like that, no systemically unwell features like scarlet fever or mastoiditis, and to give empiric antibiotic therapy instead rather than examining the throat. I think this is an interesting aspect because I think what is well known but has failed to change practice is that we are no good at being able to distinguish viral versus bacterial causes of pharyngitis or tonsillitis. What we also know with good evidence is that the vast majority of upper respiratory tract infections are self-limiting, and that the risk of complications, particularly things like acute traumatic fever, are becoming increasingly rare. And I think this must cause us to think, if we're not needing to examine throats to make a decision and we're just giving antibiotics without discretion, is this a justified approach? And I think it might be an opportune time to consider the fact that actually a watchful waiting approach to the baby or child with otitis media or tonsillitis without antibiotics would be appropriate. And this issue is addressed very eloquently in this paper that is pictured there, suggesting that unless you have signs of systemic illness like scarlet fever or an obvious sort of a suppurative complication of like tonsillitis or mastoiditis, or you're a high-risk group like you're on immune suppression or whatever, then actually the vast majority of children don't need to be given any antibiotics, and we can just manage these children symptomatically. So that's been our approach to upper respiratory tract infections. A quick word on asthma. So obviously the recommendation has been to try and avoid nebulization because it's also a potentially aerosol generating procedure. So our local guideline was modified slightly to say that unless you have a life-threatening or very severe asthma exacerbation, rather give 3 doses of an adequate dose of NDI, so 10 puffs as your first line, unless the asthma was life-threatening, and then reassess. And we brought in earlier introduction of an intravenous agent like magnesium sulfate or IV salbutamol rather than nebulizations. So we brought that in a bit earlier. A couple of comments on this. So personally, I think the one thing I've learned 2 things from asthma at this time. The first has been that children can come very close to dying from their asthma attack because of a reluctance to give them life-saving treatment. And so I think this really needs to be challenged. The risk of transmission or the risk of a child having asthma attack and having COVID is obviously relative to where you are in your pandemic, but is relatively low. Certainly, I think the additional risk of aerosolization by nebulization or by supportive therapies like high flow is not that significant that we should be withholding these treatments. And we've certainly seen children be mismanaged or undermanaged because of a reluctance to offer these things that would normally be routine because of a fear of COVID. And I think this is potentially going to lead to unnecessary deaths and to children being worse off as a result. The other thing that we've learned is what emergency pediatric emergency people and allergologists and pulmonologists have been saying for a long time, but we haven't managed to get into particularly junior doctors or people with inexperience in peds' head, is the fact that MDIs do work, and we are using much less nebulizer therapy for things like bronchiolitis or for asthma, and managing them with MDIs if it's clinically appropriate. And people are realizing that they do actually work, and that we can do without the nebs, which is a good thing to come out of COVID. Before I, actually, while I talk to this slide, Steve, if you could put up the next poll, just asking people what respiratory support they have available. I just wanted to talk to you briefly about the experience at my local hospital. So we had, at the point of doing this analysis, we'd admitted 35 cases, and we had a range from upper respiratory tract infections to bronchiolitis to pneumonia, some gastros, and a lot of incidental, interesting ones like children coming for TB, nodal compression, and going for bronchoscopy and being discovered to be positive. We've offered them high flow CPAP. We've had one ventilated child, and then some our nasal prongs. But I was just interested to know what you would use in the EC to support a child with severe pneumonia. A quick word on neonates. So we are not routinely testing asymptomatic babies born to positive mothers. We were doing that initially, but the yield was so low that we stopped, and that has been borne out worldwide as well. There seems to be growing evidence now that vertical transmission is very, very rare. If the mother's symptomatic, we've tried to, if possible, separate the baby from the mother, and if the baby's symptomatic, we've nursed them in a closed incubator, done a test on day 3, and tried to get them cared for by, for example, an asymptomatic family member with expressed breast milk. Of course, it hasn't all been plain sailing for the kids, and certainly beginning of May, when this came out, it has caused quite a stir and great excitement. So this was the original report in the Lancet of this hyperinflammatory shock syndrome, which has since become known by one of 2 names, either PIMS, the Pediatric Inflammatory Multisystem Syndrome, or the multi-system inflammatory syndrome, both referring to the same thing, just 2 different organizations with 2 different case definitions. We have been starting to see these cases over the last, say, 3 weeks or so. So this is felt to be post the acute infection. Most of these children are SARS-CoV-2 PCR negative, and for example, we don't have serology testing available, but a lot of them are positive. Their serology is positive, indicating evidence of previous infection in the overseas studies that have published these case series. Recently, the UK published 78 cases. So the clinical features are persistent fever. They seem to have a very often predominant GIT symptoms, so diarrhea, abdominal pain. Then they might have some evidence of similar features to Kawasaki disease, conjunctivitis, mucosal involvement, a very non-specific rash, polymorphous maculopapular vasculitic, and then interestingly cardiac involvement, myocardial dysfunction, and then they must have some evidence of raised inflammatory markers. And then they could be, for example, some of them look like a toxic shock syndrome. And so you need to do your cultures and treat for that and and think about bacterial sepsis before you call this a PIMS. The MIS-C case definition is very similar, except they require a epidemiological link with SARS-CoV-2. We're really seeing, I think, three phenotypes. There's the Kawasaki-like illness, there's the toxic shock-like illness, and there's the full-on PIMS. What's differentiating these, for example, from classic Kawasaki's would be that they tend to be older children, that they have certainly more gastrointestinal and neurological symptoms than classic Kawasaki's, and more cardiac involvement, so cardiogenic shock, myocarditis. This is a very helpful sort of diagnostic algorithm for the evaluation of these cases from this very excellent guideline by the American College of Rheumatology that I would refer you to. I think the important thing from an emergency medicine perspective is to consider these kids. So that maybe a convincing history of COVID exposure, maybe not, depends on the prevalence of it in your community, but they present with persistent fever, GIT symptoms, and often a rash, and then this shock. Although we are seeing some milder cases as well, so the majority of cases reported overseas have been in ICU series, but we're certainly seeing some milder cases that are not being managed in ICU. We've got the results of our poll back, and it seems like the majority of people would offer non-invasive respiratory support in spite of the risks of potential aerosol generation, and it would be interesting to discuss how people have mitigated that risk or dealt with that in their settings at the end. In terms of the management of PIMS, I think it's very much to be discussed with your local expert. Kawasaki's would get aspirin, and then there's kind of a recommended stepwise approach to the immune modulation. So mild cases, maybe no immunomodulatory intervention at all. Then a first line seems to be immunoglobulin. And if that's not working, low-dose steroids, and in life-threatening cases, pulse steroids, and refractory cases, anakinra. And others have been used as well. But I think it's very much a specialist, and there's no clear guidance as yet because of the evidence. Sorry, then lastly, the back to school debate. I would point you to this very excellent article about by Alison Monroe and Dan Rowland on this topic, or the Don't Forget the Bubbles website on transmission in children. I'd also like to point you to this resource, the South African Paediatric Association, which I'm a part of, cover this in depth in our. We've also been running webinars on COVID every 2 weeks or so since about April, if you would like to know more. But I am personally quite comfortable saying that children should go back to school. I think the risk to the teachers is far more them giving it to the young children than the young children giving it to them, or the young children giving it to each other, based on what we know about transmission risk in children. Not to say there's no transmission, but I think if we're weighing up risks, benefits, it doesn't justify keeping children out of school. Some modeling that's been done suggests that you would only prevent about 2 to 4% of deaths through the closure of schools, and we have to look at the other consequences of that. Certainly in situations like South Africa, a lot of adverse effects come from not being at school that are not purely educational, they're also social and, for example, nutritional. And we know as well that in our context, very little education has been happening effectively while children have been in lockdown at home. So I'm firmly of the opinion that children should go back to school, and I've sent my children back to school, but we can debate that later. And we've got a poll on that topic. So Steve, you can put that last poll up, just asking people what they would do with their own kids. And then lastly, I wanted to just say that we've talked about the fact that children are less likely to get COVID, that they're likely to get less severe disease. This weird multi-inflammatory syndrome, although severe, has resulted in very few deaths and is actually very rare. And the big tragedy here is actually all the other effects that have gone with lockdown and COVID. And this is going to have far more of an adverse impact on child health globally than COVID, both through the accessing of things like routine services. So, for example, vaccination rates are way down, and accessing emergency services. So, for example, we're doing far less TB diagnostic workups than we were doing previously. We know there's been reports of children presenting very late to emergency services and dying. There's a lack of access or denied access to referral centers or to ICU because there's a delay in getting a COVID result. So all these sorts of things are negatively impacting the healthcare of children. And then we're going to talk about the economic impact, unemployment and struggling economies, undernutrition related to that, poverty, the domestic violence that's happening, children caught in the crossfire, unsupervised, maybe parents going back to work, but the children are not at school. And then the other emotional toll, we know that there's growing, certainly there's a lot of anxiety amongst children, and then the educational impact as well. That graph is based on this paper, which was looking at various scenarios from not so bad to very bad, and estimating the additional maternal and childhood deaths as a result of this break in routine antenatal and child health services. Yeah. Okay, and that is my last slide. So I'd like to thank my colleagues at Tygerberg and Stellenbosch for, we've been a very hard-working team preparing for COVID. The South African Paediatric Association and their webinars and their support, and advocating for children to go back to school and for children to get the healthcare that they deserve. And then lastly, to you for listening, and to the organizers for inviting me again. Thanks very much.
Thank you so much, Andrew. And I'm just looking at the poll results, and it looks like most people, there are a couple that still need to answer it, but it looks like most people said that they'd also send their kids back to school. So that should definitely be an interesting discussion, given that there are multiple different conversations around this topic. So yeah, just interested to hear more from people about that. And I'm going to now work to unmute everyone so that we can have a bit more of a discussion.
All right, hi there. So this is Sarah Ashley. I'm in Nairobi. I was just wondering, for when you're talking about the sore throat, just because I'm sure we'll see a lot of sore throat patients, and this recently come up in a different discussion just about like the when to give antibiotics and whether the CENTOR criteria are really helpful. So I was just curious, like, given that the rates of rheumatic heart disease are quite a bit higher here than in Melbourne, where those guidelines came from saying that they don't need antibiotics, are you using any sort of criteria that's sort of a minimum contact criteria for deciding which kids with sore throat get antibiotics for strep?
So we're not, and I think as our guideline illustrates, we are tending to give antibiotics rather than not, because of the perceived risk of the rheumatic fever, for example, complications. So we're not risk stratifying, and I think the question is, how common is rheumatic fever still? I know that I asked that question of our local cardiologists. They were suggesting that actually it is becoming quite a rare thing, even in a place like Cape Town. I'm not sure about where you are, but I think that is the point. It needs to be adapted. That approach needs to be adapted to your local setting. Yeah. And then your second part of your question was around steroids. We definitely are using steroids for croup. We are not using it routinely for severe sore throat.
All right, thank you.
And then Sarah, I know you had added a bit of insight into why you chose the approaches that you chose for treating children in your hospitals. Do you maybe want to speak to that a bit, because I'm sure that resonates with other participants here.
Oh, that's what, with regards to the question about choosing CPAP or high flow nasal cannula or intubation. Unfortunately, I think in a lot of our settings, like at our county hospital here where I've been at, we don't have most of those modalities, including high flow nasal cannula, unfortunately. So that just limits our options a lot.
So what would you do with those children? Would you intubate them, or would you try and refer them and just keep them on a rebreather mask and nasal prongs until they were fetched?
Yeah, I think we would try to refer them and just keep them on nasal prongs and non-rebreather.
One could argue you're quite lucky not having high flow available, because I think it's being overused, and it's quite. I think it's about 26 times more expensive or something like that.
Wow, I'm surprised.
Yeah, I think we use it a lot. I think worldwide there's probably a growing feeling that it's being used too much. But I definitely think there's cases that would benefit from it. And I mean, there's been great studies in the African context with great innovation around how to provide relatively low cost solutions of CPAP or high flow, but it's not that widespread yet, which is a pity.
So I'm just looking to see if there are any other questions that are coming through.
Hi there, Dr. Redfern. How are you?
Yeah, no, I'm good, thank you.
Many years ago, I did a rotation through your block, but I think Liesel was there at the time, so it's good to see you again.
Cool.
So, Dr. Redfern, I was just wondering, in our adult ECs or emergency units, as they call them, we cohort our patients between high risk for COVID and low risk for COVID. Given the fact that children aren't super spreaders and they're so unlikely to contract it, is that something that you would always recommend in pediatric ECs? Or because I know that in our ECs, the ones in Cape Town that do have pediatric facilities, there are quite a few people who are separating them into cohorts. What are your thoughts on that?
So we originally were separating respiratory, non-respiratory. The original case definition was obviously quite broad if you consider the average pediatric patient, and it wasn't that hard to fit them into that case definition and to test them. And we saw children with fever and diarrhea, for example, come back positive in the early stages when we didn't really suspect them as a respiratory COVID case. So cohorting was beneficial to a certain extent, but also slightly problematic sometimes, particularly if we were trying to protect certain staff or wear certain PPE in certain areas when now you had a positive patient popping up that wasn't supposed to be there. So obviously as a hospital and a department, we moved to more of a universal precaution approach. Recently, where we are at in the pandemic, we started a few weeks back doing surveillance testing for all admitted patients, just for a trial to see what was happening, just to get a feel. And our surveillance patient positivity test rate was at its lowest 5% and at its highest 22% in 1 week. So that means that where we're at currently with our epidemic in the Western Cape, that there are going to be a lot of incidental or asymptomatic cases in your system. And so universal precautions becomes pretty essential. And cohorting is probably becoming less and less helpful. So we're still separating out respiratory and non-respiratory, but we're just increasingly aware that there's a lot of non-respiratory cases like appendicitis or gastro or febrile seizures or all sorts of things that have come through that are being positive. And as I say, I don't think we know if those children are that risky to healthcare workers or to transmitting. Obviously, their parents might be positive. We obviously screen the parents from a symptom point of view. But I mean, I think it was our first or second case, the child came back positive, and then the mother was asymptomatic and she was positive. So I'm not sure what the asymptomatic rate is in adults. It doesn't seem to be widely reported, but they definitely exist as well. So I'm not sure if that helps at all answering your question, Shwasti.
No, it's a difficult one actually, and one we're struggling with in the adult EUs as well. But your surveillance rate of 5 to 20%, that's quite interesting as well. What are you using for surveillance? Is it antibody testing or are you doing PCRs?
No, sorry, so that was PCR testing, and that what we decided is that children that come with a respiratory illness that don't need admission don't necessarily get tested. So to try and save our testing capacity and our turnaround time, and that worked for a while, particularly when we, as a whole, because of the testing policy change, we're doing less testing. And then we decided to, so then we were testing vastly less numbers of children, only if they were going to be admitted, and they would go to the PUI ward. And then if they were negative, they could then go out of a PUI area. And that was then obviously testing only the respiratory cases, and the non-respiratory or non-PUI cases weren't being tested at all. Then we decided to just see for a few weeks if we test all admissions. So you get admitted with nephritic syndrome and also the surgical cases, a number of those had been positive. And that also raised a red flag for us, because the theatre wanted to test all patients because they've got a COVID, non-COVID theatre. And so we saw a couple of well kids in the surgical ward come up positive, and it also prompted us to start saying, well, let's just start testing these children that we're admitting to the non-PUI wards just to see. And we'd had a few already come up positive, and that's where we got. So those are admitted patients. They don't meet the PUI definition, but they've been admitted for something else. And we tested those with PCR testing. And those are the ones that have been between 5 and 22% positivity rate. Last week was 14%. So that's high.
Yeah, that is scarily high. But anyway, thank you very much for your presentation, Andrew. It was lovely.
Sure, I hope it was helpful.
No, it was great. Thank you very much. Very informative.
So I'm not seeing any more questions. Oh, I do see one more. So this is from Dan Muteba, who unfortunately it doesn't look like his audio is working. So I'll ask his question. How will COVID-19 change your practice moving forward? What are your 2 main lessons learned?
What a great question, prompting some reflection. I think we have all learnt, and me included, a hell of a lot about infection prevention and control. And so I think, some of the modifications we've made to our ward environment with screens and spacing of patients, I'm hoping that we don't go back to squeezing too many kids in a room, that we keep the spacing, which is actually a far more civilized and humane way of having the children in the ward. So IPC, I think I've learned a lot personally about IPC. And I think we as a system, as a department, from junior doctors, from nurses, all the way through, have learned a lot and become far more aware, which is what the IPC people have been trying to tell us and preach to us for years and years and years, and we just have largely, I think, ignored them. So that's probably been my one big takeaway. Another one has been the use of technology in disseminating information, and the rapid and in things like teaching, webinars, but also when we were changing our SOPs every twice a week, and we needed to get information out to people quickly. That's been good. So it's shown that we can actually be far more nimble than we normally are in terms of guideline development and information dissemination when people who are maybe reluctant and technophobes are forced to use it because they can't meet face to face, and that's been as a technophile, that's been something I've enjoyed. And I suppose the last one would just be working together with colleagues across disciplines has also been enhanced at this time. It kind of has brought people together against this one common enemy, and that's also been great.
Great, thank you so much, Dr. Redfern.
At time it'd be nice to hear what other people's are, but I think we're over time because I spoke too long. Sorry.
No, I think everyone really benefited from your presentation, and we've got a lot of feedback that it was really informative. So thank you. And I think great discussion as well, and a perfect question to end on. So hopefully everyone is sort of able to take that question back to their own hospitals, to their own teams, and sort of discuss it further there and continue the conversation, as of course this pandemic is still around, and working alongside children is going to be a part of this for the foreseeable future. So thank you again, Dr. Redfern, for such an informative and engaging presentation. And thank you so much to our attendees for engaging throughout the presentation, through the polls, asking questions, and then again for submitting some great questions for our discussion. We are always here every Thursday, so please tune in next week. We'll be doing some more research focused work with Professor Breisowitz and learning a bit more about her work and sort of reviewing the literature on COVID-19. So look out for more details to come on that. And again, please let your teams, peers, colleagues know about our webinars so that we can make sure that this information is shared widely. So I'm going to end the presentation now, but again, just a huge thank you to our presenter, Dr. Redfern, and have a great day, everyone.